Now here we have some questions that we can use to apply what we just learned from both of those videos. So first things first, how do we attack the questions, right? Well, first thing you're going to do is you're going to look at the answer choices to get a general idea as to where this question is going. So here clearly I see it looks like receptor stuff, right? Adenosine receptor, GS, GQ, etc. So I have a general idea as to where the question is going. I know it's not cardio. I know it's not a biochem. I know it's not micro, etc. Right? That's the first step. The second step is you read the question. So in this case, it says, to which of the following mechanisms does the receptor for this drug act? Okay, so what drug, and then what receptors associated with that drug, and then how does that receptor act? Okay, so let's look for a drug. Basically, that's all I'm looking for, really. So I have a 4-year-old boy. So this is the third step. You read the first 2 lines focusing on age, sex, and primary complaint. Okay, age, sex, and primary complaint. So I have a 4-year-old boy, so young, comes in, difficulty breathing. So there it is, a 4-year-old boy with difficulty breathing. All right, the second line says he was playing outside while his father was mowing the lawn when the trouble began. So immediately I say, oh, this sounds like asthma. See, maybe he's having asthmatic attack. Physical exam, labs are okay, blood pressure is a little low, respiratory rate's high, of course, occasional coughing, spells, but the child is still playful. Auscultation shows the following. Okay, we leave the audio, the media, right? Videos, we leave that for last, okay? The physician orders a pharmacologic agent that rapidly improves. Now, again, I believe this patient is suffering from asthma, so therefore, what would you give an asthmatic patient, a child, to rapidly improve his condition? Now, what would I hear on the audio would more than likely be wheezing. Do I need it? No, I don't need to hear it. Because what am I going to give this patient? Most likely a beta agonist like albuterol. I say, okay, good. Beta 1 or beta 2? Well, beta 2, right? Because beta 2 plays a role in the lungs. Great. And then you say, well, beta 2, what is that? Is that cyclic AMP? Is that IP3 DAG? What is that, right? You say, oh, that's GS. Oh, okay, great. That's it. So I'm looking for GS. So we did the third step. Now let's go through the fourth step in regards to the fourth step in answering questions. We're going to go from the bottom to the top, and we're going to eliminate from the bottom to the top. So blockage of adenosine receptor, no. Blockage of cyst LT1, no. Binding to unbound serum IgE, negative. GS, yes. Activation. Activation of GQ, no. Activation of GI, no. It's activation of GS. See? Correct. Excellent. Okay. That's how we do it. Let's try another one. All right. Activation of the receptors responsible for the patient's symptoms will increase which of the following? So I see alertness, bronchodilation, acid secretion. Okay. It looks like some sort of some action. Right? Activation of the receptors responsible for the symptoms are likely to increase which of the following? What symptoms? 29, woman, with a long-standing history of asthma and eczema. She comes in with a 3-day history of watery, itchy eyes, and a stuffy nose, right there. She says she's had this before, especially during the spring, and she works in the garden. So what is she having? Looks like allergies. Okay, so then what receptors activated? Well, we have histamine receptors, H1 and H2. We know that H2 is associated with the GI tract and acid. So this is not that, therefore H1. And if I remember correctly, H1, you say, is H1 associated with vasoconstriction? No. Is it associated with heart rate? No. Gastric acid secretion? No, that's H2. Is it bronchodilation? No. Alertness. Very nice. You see? Okay, wonderful. Next one. Which of the following best represents the relative molecular affinities? Okay, of molecular affinities of the drug that should be used to stabilize the current condition. So we're looking at, I see affinities, I see receptors. We're looking for a drug that is used to stabilize the patient's current condition. So what condition does this patient have, right? Let's find out. 60-year-old man comes in because of traumatic injuries sustained in an accident. He experiences extensive blood loss requiring multiple transfusions. Okay, so the guy's losing a lot of blood. So far, nothing comes to mind. He has a central line and a catheter. Several days later, his vitals show he has a fever. Blood pressure is low. That's it. Diagnosis, you must immediately think septic shock. Pulse is high, right there, giving it away. Breathing is rapid and shallow. Legs are warm to touch. Again, more sepsis. Um, the patient is given oxygen. No change in blood pressure. Again, sepsis. There on exam, there's an area of erythema and purulence surrounding the site of central line. Okay, great. Blood is drawn, and he's admitted to the ICU. So the guy has sepsis. How do I treat sepsis? Well, you got to give them a norepinephrine, is what they say. And norepinephrine, does he have more of he has an affinity to whom? Is it phosphodiesterase? No. Is it alpha 2 receptors? Well, maybe, right? What about beta 1? Yeah, possibly. Is it alpha 1? Yeah, possibly. And alpha 1, alpha 2? Yeah, sure. So now I have to start eliminating. So now I do not believe it is alpha 1 and alpha 2 equally. No, it's not equal. It's not equal. Right? Then we're down to alpha 2. Only alpha 2? No, I know norepinephrine is not just alpha 2. So I'm down to 2. So I ask myself, well, what does my gut say, right? Does norepinephrine, you can kind of remember, think of it, whether I remember from theory, does norepinephrine like alphas more than betas or betas more than alphas? You can try to think of it that way. Or you could just say, well, what am I trying to treat here? The patient's pulse or the blood pressure? Well, it's the blood pressure. So what would I want to do? I'd like to cause vasoconstriction. And how can I cause vasoconstriction? Well, there's no way I'll cause vasoconstriction with more affinity to beta 1, because remember, beta 1 is in the heart, and that causes tachycardia, which again is not what I want. So, alpha 1, okay? Alpha 1. Norepinephrine likes alphas and betas. He just prefers alphas more than betas. Epinephrine likes alphas and betas. He prefers beta more than alpha. I'm sure if you like ice cream, you might like chocolate ice cream. You might like vanilla ice cream. You might prefer vanilla, but if there's no vanilla, you'll eat chocolate, right? And some other people, they prefer chocolate. And if there's no chocolate, they'll eat vanilla. It's all right. It's the same thing, right? Same idea. Okay, next one. The activity of this drug results in which of the following? What drug? What drug? 64-year-old woman comes in because of 3-week history of coughing and hoarseness while talking. History of rheumatoid arthritis for which she takes methotrexate. She has temperature's okay, blood pressure's a little high. On oral exam, a wooden tongue suppressor sticks to her tongue. The physician also notices that the eye seems red and irritated. When questioned, she says she admits to rubbing her eyes more frequently. So I'm thinking she has dry eyes and maybe even a dry mouth. Oh, okay, right there, that they often feel dry, right there. The doctor gives the patient pilocarpine to help the symptoms. So pilocarpine, how does that work? Is he alpha, beta, dopamine, H, right? What does he do? Well, pilocarpine is muscarinic. Matter of fact, he's a muscarinic agonist. You say, okay, great. So now this patient has trouble with her eyes. You say, all right, well, which muscarinic receptor is found in the eye? M1. You say, oh, M1. Oh, cuties have one M&M, right? So how are cuties? So that's that E sound. So I start eliminating. Adenylate cyclase doesn't sound like EEE. Protein kinase A doesn't sound like EEE. Deactivation of protein kinase C, is it deactivation? It's not deactivation, but it does sound like E. What about an increase in intracellular cyclic AMP? Now, that doesn't sound like it. And then an increase in intracellular calcium, which also has a C. So now the question is, pilocarpine, by stimulating M1, do I decrease protein kinase C or do I increase intracellular calcium? So here I would say go with your gut feeling. Now, I would hope your gut is telling you to go to E. Now, if you had no gut feeling, what would you do? You're in the middle of your exam, MBME, step 1, calm, say, whatever, and you're down to 2 answer choices. What are you going to do? What are you going to do, right? I always say go with your gut feeling. But if you have no gut, and I truly mean if you honestly have no gut feeling, meaning it looks exactly the same, tomato versus tomato, you're going to go for the bottom answer, okay? In this case, it still would have been an increase in intracellular calcium because it was an activation of protein kinase C, okay? She has Sjogren's syndrome, dry eyes, dry mouth, arthropathy, okay? All right, last one. The patient is deficient in a hormone, which most likely causes which of the following renal tubular effects? Okay, so something at the level of the kidneys. 24-year-old comes in for surgery a week after pituitary adenoma resection, so they remove the pituitary gland. He's now has increased urination and thirst. Urine osmolarity is crazy low. So what does this mean? This means that the patient is suffering from central diabetes insipidus. They remove the pituitary gland, and for that reason, he is no longer able to release ADH. So you got to think to yourself, ADH, well, we had V1 and V2, right? That played a role with ADH, vasopressin. And we say ADH at the level of the tube, the renal tubules, sorry, that actually increases water reabsorption. And we say, well, V2, well, think to yourself, you have the MAD2s, M1 alpha and D. It's not V there. You have cuties have 1M&M, so it's H alpha V1. You see, it's like no, and then M1 M3, but we said V2. Therefore, if it's not have 1M&M, if it's not MAD2s, it has to be GS, which is AAAAA. So stimulation of phospholipase C, no. Phospholipase A, maybe. Stimulation of adenylate cyclase, maybe. Opening chloride channels, negative. Closure of potassium channels, negative. So now it asks, which of the following, the hormone causes it? Renal tubular effects where? Stimulation of adenylate cyclase, or is it stimulation of phospholipase A? So your gut should say adenylate cyclase. Nice job, okay? And there it is. That's how we do it, okay, everyone? I really like using RX. I think it's a good resource, okay? I plan on doing more questions like these with you all every, twice a month. And I will be putting up more videos like this in regards to questions and of course theory. I'm going to begin with cardio. Okay, I just wanted to put up this video at the very beginning, or these two videos at the very beginning, because I find them to be very, very, very high yield because it spans throughout all of medicine. Okay, so I wish you all the best. If you have any questions, please feel free to message me. I'm here for you all. Okay, be safe and take care.